think about primary and secondary CNS lymphoma really differently, in that the prognosis is really different. With primary CNS lymphoma, the median overall survival can be in a matter of 10 years versus I've been mentioning with secondary CNS lymphoma, it's much lower. So when I think about how we manage primary CNS lymphoma, I think we need to balance efficacy and toxicity, as I had mentioned earlier, because we know that these patients are going to live for a long time. And similar to secondary CNS lymphoma, there's really no standard of care for how we manage primary CNS lymphoma. I think here in Europe, they go based off of the ILSEG 32 trial, which was published back in 2016, that typically involves matrix, followed by an autologous stem cell transplant with thiotepa and carmustine conditioning. That's sort of, I think, I would say maybe the standard of care here in Europe, but at least at our institution at the University of Pennsylvania, we've seen a lot of toxicity with some of these therapies, so we tend to use a gentler regimen based off of the Alliance 5-1101 trial. So this is, again, MTR given every 2 weeks and then spaced to monthly for induction, and then for consolidation, additional 6 months of therapy. And we found that patients tend to do really well, and again, the toxicity is pretty low. So I think that it's just really important that we, as I mentioned, just manage toxicity and manage efficacy, and MTR is really important for that. For secondary CNS lymphoma, what I think about here is that oftentimes it's really important to think about the patient's systemic disease as well as their CNS disease. So it can be really hard to manage these patients because they're so heterogeneous. So I think in terms of how we think about these two patient populations, it's really different. But it's nice to have some therapies that we could use in both populations. And I'm really excited about all the work that we published in both spaces.